Okay, let's go ahead and jump on in here. Welcome back, Joan and Patricia. Looks like we have both of you with us today. So it might be a little bit of a small group, but it'll be good. We'll have a little discussion and go over some kind of wrap-up points to conclude the Learning Collaborative. All right, if I can get my slides to advance, we'll be in good shape. There we go. And everyone knows the deal with how webinars work. And then obviously ACU and the STAR Center are presenting the webinar today. And following this, if you have anything that you would like us to share or that we can help you all with, certainly feel free to reach out to myself or anyone else here on the STAR Center team. And today you have myself and Mariah and Helen as well. And so feel free to reach out to any of us in the chat as well as we're going along today. Okay, so learning objectives, like I said, this is going to be kind of a wrap-up session. I also would like to get some input from both of you on kind of what topics would be useful to you going forwards as well. And so with that in mind, I think we'll do a little Mentimeter thing, but you can also just unmute and speak or put things into the chat if you'd like. But I will pull up the Mentimeter page. Here's the link in the chat. And I'll give that 1 second and then I'll switch my screen share. Oh, thanks, Mariah. I accidentally messaged Mariah the information instead of the whole group. There we go. All right, so first Mentimeter question was just favorite summer activity. Oh, gardening, that's a good one. We've been doing a little bit of that. My partner Kelly just did a bunch of gardening yesterday. And mine's kind of classic and boring, I guess, just going to the beach.
I'm sorry, I didn't get the, I didn't have my phone up in time. So do I just enter in the chat if I didn't get the?
Yeah, I apologize. And I can actually, I can reshare the thing if you would like to use your phone. Otherwise, it also works on the computer if Mariah put the link in the chat.
How does it work on the computer? You just type it into the chat, are you saying?
It does, yeah, you can just click the little link that Mariah posted in the chat and that'll take you to the Mentimeter. Otherwise,
gotcha. Okay.
You're welcome to put it in the chat and I'll share out. It's sorry, I jumped the gun on changing the slides there. So we'll jump back into this and then this way. All right, beach walking. So more active beaching, not just laying around and being lazy like I do. Shell hunting, I like finding good shells. Pool, hiking, gardening, excellent. I'd do any of those activities. Hopefully try to do all of them this summer. All right, we will jump to the next one. And on this one, and again, since there's just a couple people on right now, you're welcome to just share, just say things if you would prefer. But I kind of wanted to look at what is your feeling of kind of your current or planned HPET work, and how do you feel it will help with your future staffing needs? Like, do you feel it's on a good course to help with that, or do you think there's going to be staffing challenges that aren't going to be as well addressed by that? And then what are improvements you could make to that HPET work, especially after the Learning Collaborative, thinking about things? Is there anything you want to aim for? And if you've kind of figured out a way to do that, how are you going to approach making those improvements? Or is it just an outcome that you want, and then you have to plan and kind of figure out how you're going to achieve that? And then finally, how well do you feel about being able to expand your HPET work without overburdening your staff? Or if you're keeping it where it's at and you're not going to make any major changes in the near future, is some of that because of staffing, or are there other reasons that you're good with where you're at? Okay. So feeling pretty good about the HPET work helping with future staffing needs and feeling like there's some opportunities for improvement. And yeah, that staffing is a challenge to expand it. And again, I know N of 2, so not the most robust survey on the planet, but I think that's kind of good to know, and I think not an uncommon place to be. And then as far as HPT programs, is there any information or topics that you would like the STAR Center to cover in the future? Is there anything that you feel would really help support your work that we haven't covered in the past, or that you'd like us to go more in depth on if it's a past topic that we have covered? Okay, preceptor training and mentoring. All right, excellent. So yeah, kind of that training of trainers, basically. Okay, excellent. And building pathways for physicians to go through teaching health centers. Oh, I see. So from the point of view of teaching health centers, how do you build that pathway to bring physicians in?
Yeah, sorry, I was not, I
No,
did
that's
not
okay. That's okay.
very eloquently put that together, but yes.
No worries. All right. And oh, and just a heads up, something about terminology that I learned from Helen a while back, and that we've been kind of shifting our language is not using the term pipeline, but using the term pathways, which I kind of like, because I feel like pathways is a little bit more kind of, these are opportunities. So a little bit more like welcoming word, but it's also the Congress of American Indians. Did I get that organization name right, Helen? Put out a statement just saying that the term pipelines, because of like actual physical pipelines and kind of the challenges that that Native groups have had with that, they prefer not using the term pipeline in that metaphor, which I think makes sense to me. And again, I kind of like the term pathways anyway, because you don't want the idea of like people have to follow a single route, that they have kind of multiple options, but you're kind of guiding them towards stuff. So that was just a terminology thing that I've learned recently, and have been trying to rework my own language in that area. But yeah, so how do we help teaching health centers kind of build those pathways to draw physicians into them, and then continue along that route? I like that. And then Joan also said active programs for students for recruitment from local institutions. Absolutely. And we'll talk a little bit today about partnering with local institutions and just kind of broad strokes. And so I think that's good to know that going into that in more detail would probably be helpful in the future. Excellent. All right. And then we have, so topics and resources. So what have you seen offered? And it doesn't have to be by us, but it certainly can be anything that you saw offered, but you were like, that's not really helpful for us. That's not the information we need. That's not the area where we feel we're struggling with and could use more support in. So Joan said, I kind of wish we did a more systematic analysis of the cost benefit but can't really say we do. But at least you know the resources there if needed. Yeah, and that's always that, and it's kind of that balance of how much, you know, how many resources can you put into that kind of pre-planning before you do eventually just have to dive in and do it, or decide, no, we need to wait. And then go on to, I believe, the final slide. What do you feel is your biggest current challenge with workforce? And this one can be kind of a, you know, is it recruiting a very specific type of staff, or is it, yeah, so recruitment or retention of physicians. Okay. So physicians are the hardest ones to find or keep around. And providers feel they are uncompensated for the level of productivity. Yeah. Okay. Oh, and bilingual counselors. Yeah, I imagine that is a challenging one. Okay. All right, let me switch back to the slide deck here. Okay, so obviously we won't go into breakout rooms, but I appreciate the feedback from both of you. Again, I want to kind of make sure that we're really thinking about what will help people the most when we're designing trainings and everything. So that's really helpful to know kind of what we're on course with and what maybe we need to add in or incorporate to our next round of trainings. And then as far as either of you, if you'd like to share, is there anything you're going to be doing, you know, immediately following this learning collaborative to kind of continue, you know, down your either building, growing, changing your HPET program in any way? You know, and do you have kind of near-term goals or goals that are further out for what you'd like to see happen with the program, or what you're kind of aiming to do with it? Or if you're like, nope, we're good, like steady as she goes kind of thing, that's fair as well.
I can speak on this. So we are going to be exploring the teaching health center model, and we've been in contact with a community health center in Spokane, Washington that was actually featured in one of the HRSA newsletters about you know, how well they have done as a teaching health center, and sort of exploring what does the funding look like, how do you form the consortium, who is responsible for what, et cetera, et cetera. And so those are one of the things that we're looking forward to explore. We also are looking to partner with other training centers, if you will, for medical assistants. I think we have still some more to explore outside of our like normal, like traditional partnerships that we have had. So we're looking at that as well. And one of the things that I think specifically I need to do is to forge relationships with the graduate medical education residency program directors in our area and beyond, to help create pathways to potentially recruit some of these you know, future physicians. You know, maybe we could have them come and do some rotations with us, but obviously we need physicians in order to offer the rotations. So, you know, getting the physicians is like step one and critical. But that's sort of some of the things that we're going to be working on.
Excellent. That's true. And let's see, Joan, you're on mute, but I saw you raised your hand earlier.
I thought I had unmuted. Patricia, what kind of organization do you work for?
Sorry. Yeah, I'm at a federally qualified health center
You
in
are.
Fort Worth, Texas.
Okay. But so I thought you said you were looking to collaborate with other FQHCs. Is that what you're saying? Or with medical?
No,
with-
we're actually looking to
academic?
collaborate with academic institutions in the
Oh,
area.
okay. Yeah.
Sorry, maybe I misspoke, but
No, I think that's what you said. Sorry.
yeah, that's what we're in. We're trying to to kind of feel out what it would look like to form a consortium and to kind of get a feel for, is that something that even these academic health centers want to do? You know, for those that have been in existence for a very long time and are very successful, you know, what is really the incentive for them to do that? Other than just, you know, altruism, I guess, by, you know, partnering with us. But, you know, if they're interested in any way in expanding their graduate medical education residency slots to better, you know, to grow their program or on other reasons, then it would make sense for them to join the consortium. So we're trying to kind of work through that, and some beginning conversations will be had later this month.
Fantastic.
You know, yeah, I'm interested in my environment in Bridgeport, Connecticut, working with an FQHC. I feel like academic programs are breathing down our necks, trying to use us as a clinical rotation site. So it's just, I'm confused, surprised if you're not experiencing that same.
Yeah, so we have had good partnerships with current institutions. So we have two, like our county hospital. We have physicians from the family practice maternal child health division. So the FMOB docs, they come in, and there's 4 of them. They rotate at any one given time at one of our locations to help us deliver obstetrical care. And then another one that we recently did was partnering with a for-profit hospital in Fort Worth that created an OBGYN residency program, and their continuity clinic is at one of our locations at a different location. So those are 2 kind of standing academic relationships, if you will, but there is limitations in having it just be that type of relationship. I think there is a bigger, there's a bigger vision when we all get together to understand that I think each of the institutions in this area, to help bridge these and create these pathways for future physicians to stay in the area. It's important that we kind of think broader and bigger than just, oh yeah, go rotate there. And that's, I think, the way that it goes right now. They just go, oh yeah, we'll go do your continuity clinic at the FQHC. You know, they have a great amount of pathology over there. You're going to get great training, and that's good, but we can do much more. One of our limitations, though, is that we don't have physicians on board. And so that limits the amount of, it limits students, and it limits the residents that can rotate. So we do have pediatricians. We've got 3 pediatricians, but there's no specific pediatric residency program in this area. Okay, so the ones that are mostly known are family practice or internal medicine or subspecialties. And we don't have internal medicine docs, and we don't have family practice docs. We have mid-levels only right now. We have had a tremendous problem in recruiting and retaining physicians in those specialties. So if we had the staff, we'd have the residents, but we don't. So I guess my point is, I'm looking for I want it to be a win-win situation. The academic institutions want to send their residents and students to rotate with us. Great. I need your faculty, because I can't recruit and retain physicians on my own, namely because I'm competing with them. right? They're the ones that take the physicians that are considering us. And so if you bring the faculty, then, I'll lend you the space, but I need you to, send the faculty that can help us see patients and supervise our mid-levels as well. So I think to us, it's a little bit more than just having them come and rotate.
Yeah, I guess I'm sorry, I wasn't really focusing on understanding that you're talking mainly about physicians in training, because the people that are breathing down our necks are APRN programs, PA programs. We have
Yeah.
fewer medical students than we have mid-levels coming as students. And frankly, we are happy to have some doctors we have, and we have one arrangement with a local hospital like what you're describing, but we have a lot of mid-levels on staff, and I don't think that's a problematic equation for us. And so we're happy to have a lot of mid-level students that get a taste of us and, maybe like it.
Yeah. And we're, right now we're well staffed with mid-level providers, but because they don't have the direct supervision of a physician in their immediate area, I think they function under a little bit more stress. They kind of don't have that support. Especially there in one of our locations, there's a single family nurse practitioner, right? And so she has like literally nobody in her vicinity other than a pediatrician and an OBGYN. So she's really kind of out there, and we have not taken any mid-level students because I feel badly having them not only be responsible for seeing like all patients without the physician support immediately there, but then on top of that have a student that they have to proctor. Like, it's just too much. So I'm not going to say I've cut it off, but I have blocked, I have not accepted any mid-level providers since I started in this organization, which was in 2020. So we have not had PA students or F&P students rotate because we're just not at a place where we can place that kind of burden on our mid-levels. It's an interesting situation.
Yeah, I would agree. I mean, we certainly have a challenge recruiting physicians as well, but I guess we have more of a backbone than you do, so it's not such a problem.
Yeah.
That sounds challenging. I do like your idea of, you kind of mentioned having some of these academic centers, share their faculty. And I wonder if there's opportunity to do like almost staff sharing, because some places, they can't quite hire enough staff so that when someone goes on vacation, they have full coverage and all of this. I wonder if there's a chance to partner and kind of each organization offer like part-time employment that kind of sums together as full-time, or even partner to create like a full-time position that floats between two organizations.
We actually have explored that, and we're with one of the academic institutions that we've partnered with is exactly for that. It's for like a job sharing. However, even they have had a hard time. Like, they haven't been able to successfully recruit, and we've been working on this for about 2 years. So I think in our unique environment, we are in Tarrant County, right? We are the county that's next door to Dallas County. Dallas County gets all the fame and glory. And when people want to go work in North Texas, they want to go work in Dallas. Okay. So Fort Worth already is not like what people think of when they say they want to come work in this area. So that's strike one, right? And then strike two is, we cannot compensate physicians like the other institutions in our area. We are actually the only FQHC in Tarrant County, believe it or not, with over 2 million people in this county. But all of our competing institutions can offer a much better compensation. So there is no like fame and glory to go work for an FQHC, where there is nothing else to do other than just to see patients, right? You're just cranking it out. And physicians aren't interested in that. They want to teach, they want to be around residents and students, and they want to go and do research, and they want to be able to publish. And when, I can, pay them, I'm going to make this up, $200,000, and the next institution says, well, I'll pay you $225, and you can get all those other things you want to do. Well, that is a no-brainer. They're like, oh, forget the FQHC, I'm going to go over here. So it is, I mean, when I say nearly impossible, it is nearly impossible. It has been really hard.
So do you attract people that are looking for loan repayment under the National Health Service Corps, or not particularly?
Yeah, we are, but interestingly enough, even with that, they don't bite. Like, I don't know. Like, I guess, I'm a National Health Service Corps scholar, right? I did my loan repayments with an FQHC in Houston, and I stayed well beyond my time after I paid off my loans. But that's just not, providers are not enticed by that. I really feel like, because I've been, this is my first CMO role, but I had been as a director of a pediatric FQHC in Houston for almost 7 years. And the way that providers think today about employment and what they want to get out of employment is very different than the way it used to be. People now, they don't, the money is not, the compensation is a driver, but some of the perks aren't that big of a deal. Like, yeah, I can get loan repayment over there, but I'd much rather be doing this over here instead of paying off my loans, with 4 years of work. I'm going to make that up. So people don't want to work for, it's just, I don't know. I can't explain it. There's just a whole different way of thinking about what physicians want out of their career. And it used to be that physicians, I'm a physician, right? So it used to be, we were like, okay, I'll graduate from medical school and I'll just go work, like I just go see patients all day. Well, that's not the case anymore. People don't want that. People want this, I want to work an alternate schedule. I want to decrease my direct patient care time. I need more admin time. I want to do this. I want to do that. And they expect to be compensated for everything that they want to do, yet they're not bringing in the productivity, right? So from especially the CEO standpoint, they're like, what? You've got to be crazy. How are we going to keep our business afloat? It's just different times.
Oh, Joan, you're back on mute.
I worked for a number of years in staff model HMOs, and which are sort of, a non-existing entity anymore. But so many providers at that stage felt, I don't want to do all that other stuff. I want to practice medicine. So that's really different from what you're saying.
Yeah, it's gone full swing the other way.
I love this HMO because you do all the business crap. I want to practice medicine. Just leave me in the clinic.
Yeah, no, that's so different from what people want these days. It's just interesting. I think, I'm sure everyone's probably tired of hearing this, but I really think that the pandemic, forced a wake-up call in our society. And we're still feeling that reverberations of that, throughout our, the employment market, and even up to providers. I mean, a lot of providers don't want to work full-time now. They want to practice medicine, then they want to also own a business. They want to do, other ventures, I don't know. It's just not the same. It's not the same at all.
Yeah, that's interesting. And do you think the wanting more admin time, do you think some of that might be people being gun shy of of getting stuck with a bunch of admin work and not being, covered for those hours, as opposed to like, if it's like, no, truly, you're going to see a bunch of patients and you're not going to end up having to work a bunch of like nights and weekends doing your EHRs and stuff.
I think people feel like, I think it's an answer to a couple of things. I think for one, and I don't know if this is just unique to the particular providers that work here, but they feel stressed. They take home their work. They aren't done doing their documentation. We've explored multiple different avenues of how we can make documentation more efficient so that they don't have to spend that extra time. But at the end of the day, it's not just documentation, it's also reviewing the labs, it's sending out lab letters, it's calling patients, it's tending to calls, it's so many other things that they're like, it's just impossible to get this done. You're asking, you're compensating me for a 40-hour work week when I really work 60 hours. And it's just not fair. So then give me more admin time so that I can actually get the work done in 40 hours. Well, it doesn't quite work like that. So that's sort of the attitude that I feel is totally like, you want me to, I'm not going to put in more than 40 hours. Like, I'm done working these extremely long hours as a physician. Physicians were expected to work hours and hours and hours. You don't get a penny more for putting in additional time at home, and people are done with that.
Yeah, and maybe, oh, sorry.
Sorry, I have a question. So when you say it doesn't work like that, like why not? That's maybe seems like a stupid question, but like why can't we just compensate people for the hours they're working?
Because physicians, especially physicians, I'll stick to that. Physicians are already highly compensated, right? So if a physician is making, $220,000 a year, but they are working, 60 hours a week, and you've got to pay them, even if it was a base salary. Let's say you cut that out and you calculated an hourly of $100. I'm sure it's probably more than that, but you'd have to compensate them additionally, and you're just not bringing in the revenue to cover that. So from a business standpoint, it just doesn't make sense.
But why not do what they're saying of making the workaround so that they don't have to work those 20 extra hours a week, so that what they're expected to do fits into the 40-hour work week, which was
how do you do that?
Yeah, then that means that you would be cutting down on their productivity, right? On their encounters. You'd have to decrease their encounters so that they can make it all fit within 40 hours. And that means that you're not going to be able to sustain your operation. How can you if your revenue is being cut into by decreasing the amount of patients? See, the issue is it's not the patient care that's the problem. It's everything else that happens after the patient leaves. Okay. So this is, as a physician, I enjoy seeing patients. I could do this every day, all day. Right. But and I can do a high level. I'm a pediatrician, so I can do a really high volume of patients. If I had a scribe, if I had a dedicated medical assistant, a dedicated RN, a dedicated care coordinator that could help me do all of the things that I don't have to do those. But
and you not have those because of the revenue piece, or
correct.
because of work?
Yeah,
like
because they cost. Yeah, because they cost money. So, I'd have to then employ, an RN. I'd have to employ, these dedicated roles for each provider. When you are providing uncompensated care and you're getting paid $40 for an encounter, how can you make that work? You're not even breaking enough money to pay the provider. So business-wise, it doesn't work. And so the answer is no. So the CEO says, absolutely not. You have to do all of your notes. You have to do all, and don't ask
How
me to
much
see
does
less
the
patients.
CEO make?
Well, I don't know about that. All I
Yeah.
can say is that the physicians get compensated, well, but you just cannot, compensate above and beyond that and expect to cut down the productivity. So I guess my point is that, the newer generation of physicians are done going above and beyond. They're done with it. And they're in this mindset of, no, I'm only going to give you 40 hours, maybe a few hours after that, but don't expect more than that because you don't pay me much more than that.
Another little wrinkle to what you're talking about, Patricia, is I just came out of a courageous conversation. We have a health equity, diversity, equity, and we call it diversity, health equity, and inclusion group. And we're starting a series of conversations. And today we were talking about cultural competence and cultural humility. And so added to all the requirements that you're talking about, there was this great discussion about how providers need to take the time to listen so that they understand their patients, their clients, which of course is true, but when you're supposed to be cranking people at 15-minute slots, that gets difficult. So it's just, it's another element, I think, of frustration that there is this expectation.
Oh,
and,
yeah.
and actually, and the provider, the doctor who joined this conversation and spoke out, is an old-time doctor and she's very committed to doing this, but she said, when I was in my own private practice, I could give somebody 40 minutes and the next patient, being a little discombobulated, would understand because they knew they'd get 40 minutes if they needed it. But I can't do that in my FQHC role. I can't.
Correct.
I'm not allowed to.
So
Yeah.
Helen, I wanted to, let me rephrase. If we were in private practice and getting reimbursed by private insurance, that's a very different scenario than it is for those that serve underserved communities. So a private insurance, patient, I can dedicate like Joan said, I can dedicate a 40-minute visit. I can bill at a 40-minute level, like the 99214, because it's a 40-minute visit. I'll do my ICD-10 codes and my reimbursement rate is pretty good. Okay, so I'm making back what I'm giving, right? In FQHCs, it doesn't work like that. We have, especially in FQHCs like mine, and I don't know, Joan, what your payer mix looks like, but our payer mix, because of the way our county, the political position of our county, we serve a disproportionately high number of uninsured patients. About 60 to 70% of our patients are uninsured. It is a huge number, where the average FQHC in Texas even is 40% uncompensated, 60% insured in some way, shape, or form. We're the opposite. So the patients who are uninsured and apply for the sliding scale fee, which most of them do, and most of them qualify for the lower tier, which is $40. They pay me $40 to treat them, run their point of care test, spend all the time I needed to spend with them. And how many patients do I need to see to make up for that privately insured patient, right? I got to see probably 6 patients, that are uninsured to make the same amount of revenue that I do for one insured patient. So we're in a really bad situation, right? The CEO sent me a message today, an email, like the providers aren't producing. Then I have to turn around and go tell the providers, hey, y'all need to go see more patients. How can you expect for me to see more patients? Like, I'm already seeing as many as I can, so it's just like this vicious cycle. But I think part of it has to do with the way that we are structured as a federally qualified health center.
I have to say, it's partly the state you live in.
It's part of the what?
The state that you live in. Move to Connecticut, Patricia, because we have a really generous Medicaid program. And so, we have a really lopsided, we have a fairly substantial uninsured base,
Mhm.
but very heavy Medicare, Medicaid base. And Medicare, of course, is not in state control.
Yeah.
But, you know, Texas, so you need to be lobbying your state legislators. Good luck with that in Texas.
Don't hold your breath, Joan.
I know. Well, I'm glad to live in Connecticut, I'll be honest with you. But the other thing I was going to say, tying back to the subject of this echo, is, you know, in theory, if you're bringing in some trainees, then you can at least be extending your reach a little bit with people that are, you know, competent enough wherever they are in their training to be able to see patients and bill under whoever they can bill under.
Mhm. Yeah. Yeah.
And so that's one of the virtues of having patients,
Yeah.
of having students.
Yeah, no, you're totally right. It is, you know, partly, you know, so Texas, you know, did not expand Medicaid. It's like super broken. You know, we only cover, you know, kids and pregnant ladies, and that's it. Nobody else gets Medicaid in Texas. Or you've got to be like disabled and extremely poor, something like that. And that's it. And so, but then to make matters worse, our county hospital, unlike Harris in Houston and Parkland and Dallas County and other counties in the state that are large metropolitan areas, our county system does not, anyone who is not a legal resident of the United States is not eligible for any kind of discounts in their care at the county. Okay, so what that means is that all of those uninsured patients end up coming to us. So we take the disproportionate number of those patients because they're not given any kind of discounts at the county level. Furthermore, the specialty care is nearly impossible to get for some of our patients. So it's just a bad all around situation. So sometimes we have to actually, after when the pandemic happened, Dallas County actually opened up their county system to the surrounding counties in the area, because before it's only supposed to be for your county. So Dallas County, if you're a resident of Dallas County, they don't care if you're a legal resident or not. They just say, if you reside in the county, you are eligible for discounted services at the county level, at the county hospital. And not so in Tarrant. But when the pandemic hit, they opened it up. And so now we send a lot of patients over to Parkland, right? So now it's eating into Dallas County instead of Tarrant County. It's just a hot mess, Joan. It's a hot mess.
Yeah. And you know, and I wish we could like solve all the issues on this webinar, and like, you know, I'm more than happy to talk through and just like, you know, bounce ideas around. I think your partnerships with the academic institutions and sharing staff, and maybe there's ways to even negotiate like, you know, tuition exchange so that you can have people scribe at your health center, and in exchange they get, you know, tuition reimbursed if they're, you know, in another medical program at an academic institution or something. I don't know if there's options there. I think that sounds like you're on the best track you can be in a really difficult situation.
Mm-hmm.
Yeah, Patricia, I can tell you, we do have some scribe service, and I know nothing about it, but I mean, if it's something you're investigating, maybe I can put you in touch with somebody here. I don't know who, but I could figure that out. But I think we've tried to recruit some students to do that. I think mostly we just use a service. I don't know how we afford it, but I guess we must figure somehow in the equation that it must enhance productivity. So
yeah.
Yeah.
Yeah, we're exploring, we've purchased the additional module that allows for dictation, so that now our providers can do some dictation while they're seeing the patients. We've looked at really maximizing our ability to do like quick note documentation in the EMR. So that basically you kind of plop, you know, a pre-written note for a known condition into the chart, and then you just kind of tweak as you go. We've done so many things to try to decrease that provider burnout in terms of documentation that I think, I mean, we're trying everything that we can, everything I can think of to try to exhaust those things. And we're in a better place now, believe it or not. But, you know, we just continue to work and see, and, you know, we're making a huge push right now towards integrated care, and trying to really leverage the expertise of front desk, the medical assistant, you know, the referral coordinator department, and the nursing department, and the providers kind of all working together in behavioral health, all in the mix to try to see how we can, you know, my point is that everyone in the organization, regardless if you're the provider or not, we're all accountable for the health of these patients. And though the provider is burdened to be the one that's solely responsible, right? The provider has to not only tend to what's in front of them today, you know, to monitor their diabetes, hypertension, whatever it may be, but also to close all the care gaps, all the screening stuff, and that you got to do your mammograms and your, you know, colorectal cancer screenings and everything else that you've got to do for your UDS metrics. Oh, and by the way, they're also depressed. They're, you know, their PHQ-9 is positive. And so, I mean, it's just so much that goes on in one single patient that it's just impossible for one person to handle all of it. But that's traditionally how medicine functions. So I'm trying to really push the notion of collaborative, team-based care, integrated care. You know, we're trying to push integrated care huddles so that everyone comes with their lens prepared to talk about that patient today and what they need. So, you know, we were trying to do as much as we can to try to ease up that burden on the providers, and really, you know, increase quality of care. But it's interesting. It's going to take us down a journey. And, you know, that's sort of where we are right now, where we're headed in terms of our kind of our strategic plan as an organization.
Do you have care coordinators or, you know, community health workers or something like that on the teams?
Yeah, we do.
We just in Connecticut got passed legislation to reimburse community health workers. They have to be certified. You know, this has been years in the coming. Are you reimbursable part? Are they a reimbursable part of the team?
So they're reimbursable under case management for Medicare.
Yeah.
However, recall that our Medicare sliver is about 2% of our population. So that really is neither here nor there for us. If we provide the service, we're providing it and we don't get billed. Right? We don't bill it, because we can't just bill the Medicare patient and not the uninsured, right? Not the uninsured patient. If we bill, we have to bill everyone. So by billing everyone, we're concerned that that may put it out of reach for uninsured patients. So we just provide those services free of charge, essentially. Sadly.
Yeah.
So somebody wrote on the chat, you know, asking if TAC does advocacy. Yeah, they do. They do. And TAC has been great. That's our PCA for Texas, and we work a lot with them. I think though, even though we work with TAC, even so, like our situation is so unique, because it's just not the case for the majority of the Texas FQHCs. It's very interesting.
You know, I wonder, this is sort of a long shot, but I wonder if there is federal COVID-related grant funding that could help with any of these, like with community health workers. I know that's been an element in the federal perspective about the importance of that kind of care coordination role. And grants are never a great solution because they're time limited, but you know, you might get some money for a while and maybe it would work, and maybe it would make a case for itself for sustainability or something.
Yeah, we've actually, the community health worker, the one that we have right now, we were able to get her because of grant funding. And of course, that when that grant expired, we had to go after more grant funding. So yes, we do go after that, but you're right, it's not the ideal way of it's definitely not a solution. It's a temporary fix. But as long as our payer mix doesn't change, I don't foresee us being able to do anything different.
Yeah.
So yeah.
Those of us who don't live in Texas don't realize that Dallas and Fort Worth don't all feel the same. I mean,
They're not.
The airport is Dallas Fort Worth. So what do I know?
That's hilarious. Don't
Yeah,
ever. So I am from Houston. Okay. I moved to
Okay.
Dallas in 2015 December. And I did not know, right? There's a huge thing about like Dallas and Fort Worth, but pretty much don't like each other. And they don't see each other. Like it's a whole different, Fort Worth it's a lot more laid back, a lot more cowboy. And Dallas is very metropolitan. There's this expression called "this is so Dallas," because it's like
Wow.
everyone gets dressed up to go to the grocery store, with full on makeup and false lashes. So there's a very interesting rivalry between the two cities, and they're very far apart. So like from downtown to downtown, it's about an hour's drive. And so they're not close together. And so even though people say it's DFW, it's not one and the same. And there's a bunch of little suburbs all over the place. And, and then Houston really hates Dallas. And, it's just interesting. Yeah.
So all you share is the airport, is what you're saying.
Pretty much. It's sort of the no man's land, sort of like the Swiss, like Switzerland, right in between. And that's about it.
Well, this is educational. But I'm still not moving there.
I don't blame you. Right now it's 106 degrees outside.
Oh, Lord.
That's without the heat index. So when I say pool, I really mean pool. It's pool time. Yeah. So that's why so many people in Texas have pools. I mean, there's a pool pretty much in every single house down here.
Well, yeah, that's a challenging context. I'm from Florida, so another non-Medicaid expanded state, but certainly like within Texas, a challenging environment to run a health center. You are in a hard spot. So I'm very impressed with all the effort you're making to keep everything running down there. All right. Well, we will move on. I have just a few slides based on things people had brought up in the past to go through. I think maybe it sounds like all of her work with some of the academic institutions. Patricia could probably teach this part about trying to build and maintain partnerships. But we'll go through these real quick, and then the last few minutes, just anything anyone wants to bring up. Or anything else we can offer in the future to help everyone out. So again, biggest thing with any of these partnerships, whether they're with other educational institutions or other healthcare organizations, community organizations, schools, some combination of everything, is just really to make sure to be communicating with the partner. And I think this is the biggest thing, and Patricia mentioned it a little bit, is sometimes just asking for stuff. And sometimes people kind of, I think, are a little bit afraid to kind of leverage that opportunity that they have as a health center. Like you said, you are a really attractive place to rotate, physicians and other learners through, because you have really, diverse patient populations and everything, and great opportunities to practice medicine and do lots of patient care and everything. And then you also do have positions. If you have staff shortages, you have positions, and a big thing is organizations want, educational institutions want their students to come out and have jobs. It's a little bit, looks a little bit different for physicians because they have the whole internship residency career model. Than say like nurses who come out of school and then it's just apply and find a job. But through all of these situations, you have that huge offer of, hey, this is a place where you can rotate your students through. and then they can potentially find a job afterwards. And that is much more attractive to an educational institution than I think a lot of people realize. So really kind of remembering to play that card. And then once you have a partnership established, maintaining that communication. One of the biggest ones is making sure that you understand their goals, like what are they specifically looking for, and then sharing with them what are your health center's goals, and being really upfront of here's our situation. And it's one of those things, institutions and sometimes individuals can be very driven by the flow of money, but you also have individuals within institutions who like they're truly there to do really good work. So even big academic institutions that sometimes can seem a little bit cold to mission driven work, you'll still find individuals that can be your ally within that organization and can really help to make the most out of those partnerships, and can help to problem solve some of those solutions, like say staff sharing and things. And as part of that conversation, what is your ability to support their staff, right? What can you offer to their staff as far as maybe opportunities and things like that? And then what's their capacity to support you and your staff? And how do you kind of make the most of the situation for both your organizations? Then also, obviously, what's your capacity to support their learners, right? They have learners that are coming into your organization, and how can we get these students the best education possible, right? And then how are you going to coordinate on these things and update each other as situations change? Because you may have that situation where, oh, right now, our I think you were saying it was the OB or pediatrics, one of your departments, you were like, it's a lot of advanced practice providers, but they're maybe not at a point where they're going to be comfortable taking on a bunch of learners. But if that changes, or if you are like, okay, we can take a bunch of learners, and it's like, okay, we're at capacity, how are you going to communicate that? Do you have regular meetings and lines of communication established? And having those people kind of assigned, where it's part of your job is to liaise with our partner institution and make sure that we're kind of getting the most out of this partnership possible. And then obviously you want to kind of evaluate successes. And so one of the big ones is just how are learners providing feedback to your organization, to the educational institution, and how's that being shared with you, so that again, you can provide kind of the most valuable environment to learners as possible. It's also an opportunity to interact more with the learners and kind of start engaging in some of that recruiting. And then once again, evaluating success, you want to look at like what's going well and what can be improved, and kind of sharing that between your organizations. And that should be part of that communication process as well with these partnerships. It's the simple thing is just it's a lot of communication. And so building that kind of personal relationships within that larger organizational relationship is really important. So our biggest goal obviously is to turn those student learners that are coming through into potential recruits for different job positions, right? So again, being really proactive about it, telling the educational institution, this is our goal, we need these kinds of staff, and then thinking about, how you're going to really actively engage in that recruitment. And so we will look at first kind of recruiting if you have a grow your own style program, right? So if you're, say, training your own medical assistants on site, or you have a community health worker training program, things like that, you are going to be recruiting people to come into that program, and then presumably recruiting out of that program for, careers, for long-term positions. And so you have that, exciting thing of you can come learn this skill. You'll be able to do it, say, for free or stipended or on a salary. And that also provides opportunity to recruit within your own health center, right? And to kind of capacity build. So, I hear lots of medical assistants who started out as, front desk. They were just doing, that patient triage as people come in, and kind of, helping people fill out paperwork and getting checked in for their appointments and everything. And they saw the medical assistants doing a little bit more, and they're like, oh, I want to go do that. And some of them even go on to nursing or medical school, or take on other positions at the health center. And so kind of making sure that you're doing that outreach amongst your own staff. And then especially, this is a good opportunity to use community organizations. And sometimes you can even find, opportunities for extra help. You may find, retired medical practitioners that want to come back and will help teach just as volunteer hours. And so it's a, something where they're not paid, or you can hire them, part-time and stuff. And they're coming in to kind of get to do something in their retirement, and help to train the next generation. So lots of opportunities there. And then if we are recruiting from, cohorts on clinical rotations, so whether it's nursing students or PA students or something coming through your health center, or it's physicians, going through internship or residency and doing their rotations there, or medical students coming through. I think one of the biggest things that often gets overlooked is it's like we have these student learners going through, but no one's talking to them about how to get a job here afterwards. So making sure they have that moment. And when I say guided, on that slide, give guided time for learners, I mean like a person takes them and explains what's going on and introduces them, says, hey, here's, our HR director, or here's the person in charge of recruiting, or our chief workforce officer, or whoever it is, and says, hey, get to meet them, when you're ready to apply, for jobs, remember us, here's the information, here's the website, here's how you get to know us. Talk to us about what you did. Here's how you want to present yourself when applying for jobs. It can be quick. It doesn't have to be the whole long, hour-long class on how to get a job. But I think that's a really important opportunity when you have those learners on site, is take them and introduce them. That way they can do those weird things that you're taught in job application support, like address your cover letter to someone. Like I've been told that so many times, it's actually really hard sometimes to know a name to like address a cover letter to, but you can give them those little things, and it just helps to form that connection. So then they'll feel comfortable applying for a job with you, which is something that I think very few people feel really comfortable when they're submitting a job application. Maybe that's just me, but I think it feels a lot more comfortable if you know someone, you feel like you've been invited to apply. There's a much better feeling going into something than if it's just like, well, I went through there one time, I was a student, I got yelled at by this one person, this other person was really nice to me, I can't remember either their names, I don't know who to write to say I'm interested in a job. Like, you give them that information and kind of start them on that path. And again, working with the educational institution partner, if it's a community college or a state college or a, thank you, Patricia. But whatever academic institution it is, talk to them. They may even want you to come in to classes, to have someone come in and just talk for 20 or 30 minutes about your health center and the fact that you're looking for staff. So say they're like, okay, we have, a group of RNs who are in their final semester. They're all applying for jobs. Do you, if you reach out to them and say, hey, I want to come talk to your RNs about how to get a job, they're probably going to be really excited to have someone come in to the class and talk, and it doesn't take that much time to do that. So that's something really important. Again, even medical students, they're going to go through residency and probably forget everything that they heard from, some guest speaker, but there might be a few that are like, oh yeah, health centers, or it'll ring in their head when they're out there looking later on. So kind of taking advantage of those opportunities. And again, remembering, instructors and academic institutions really want people to come and tell their students they're going to get hired, right? That's kind of one of their marks of success. So really taking advantage of that opportunity. Oh, and then if you have staff, so say you have a staff member who graduated from a training institution, obviously having them do that. And this is where one of those things, if you have a really great workplace and people like working there, awesome, they're going to spread the good word about that. If you're not treating your staff well, it's obviously going to come back to bite you if you have someone and you're like, oh yeah, go tell how much you liked it, and there's like, well, I don't really want to because I don't like it here, right? So making sure you're taking care of your staff and doing all those things for retention will also benefit recruitment, because then those staff will go out and let people know how great a place it is to work. All right. So again, for any recruitment effort, it's really helpful if you can have someone who has that dedicated as their sole role, ideally. But we all know that, in the real world, sometimes we can't create a chief workforce officer. If you have the opportunity to, the STAR Center does have a resource, and I linked it down there on the slides, that helps with developing that role, but at the very least, make sure that it's carved out in someone's time and job description, and they're given the resources and training to really make that into part of their job, so that they can do it really well. Because if it just gets thrown to someone, and anyone that's worked in any kind of like HR admin capacity knows that sometimes stuff just gets thrown at you and you're like, well, now I have to figure out how to do this. It's really hard to write good job descriptions to, really effectively recruit people, to keep all of this stuff that we just went over in a couple minutes in your head as you're going through, and make sure that it's happening and happening regularly and you're reaching out to people. So kind of make sure that you have this carved out for one or more people, and that they have those time and resources to really make that effective. And then we have much longer presentations on crafting good job announcements, but I figured I'd put this in there. You can always go back and review the details if that's something you're interested in, or if you have staff where you think this would be useful for them. But that's another really important thing. Obviously, if you're rotating learners through and you want them to apply for a job, you have to make them aware that you have the job. You have to show why it's attractive, and you have to make a reasonable process for them to go in and actually do that job application before they can get hired, right? So having your ads written in advance and making sure that people relevant to that position have written them, right? Very few places that I've talked to, if they put out a medical assistant job ad, have had a medical assistant look at it and say like, oh yeah, that makes sense for what I do. But it's really important, right? If you're hiring for maintenance or custodial staff or medical assistants or a physician or a nurse or whoever, someone from that role should look at it and say, yeah, the job description as you've described it on here very clearly shows what this job is about, what I'm going to be doing, right? Sometimes when we have those conflicts over, well, people just don't want to work in this environment. There might be people, like it might be that you have a really challenging work environment and it's going to take a lot of sorting through, but you can do some of that if you have a well-written job description where people say, yeah, like I'm really dedicated to this work. I like working here. This job description conveys all of the things that I like about this job and all of the challenges that I would want to know about coming in, so that you're going to select down and get people who really want to be in that job, rather than someone who maybe is not going to work so well in the particular challenges that your environment offers and may not be as excited about the rewards that come from that job specifically, right? So we're trying to kind of match what are candidates' motivations and goals, right? So mentioning your mission, this all kind of goes with what I was just saying, mentioning your mission, talking about the community and the population that you get to serve and everything. It can be kind of challenging to provide people good information about the challenges, what a job is going to actually be like, and making sure that someone's not going in blind and thinking it's going to be, oh, I'll see 5 patients a day and it's super easy. You don't want that if that's not the case, right? But also not talking negatively and saying like, oh yeah, come here, you're going to get burned out in 2 years and want to quit, right? So we got to find that middle ground of where we're talking about like, okay, what are the challenges, and we're being clear about it, but we're also highlighting the benefits and the mission and these things that will really be good drivers for the staff that are really going to work well in the health center environment, right? We don't want someone who's looking to make $1 million a year, but we do want someone who's like, I want to work at a place that treats its people well, but where I'm really working a lot to serve a really important community and a really, unique patient population, right? And then, so that I jumped ahead. But then also making it kind of personal and making a little bit of that connection with people. Even if you have a good quote from someone who works there and works in one of those positions about why they like working in that position, that can be something that's really compelling to put in a job advertisement. Obviously making sure that you're watching out for some of these phrases that do connote burnout. So like under pressure or super high pressure environment, those things just tell someone that like, oh yeah, we're going to work you until you burn out and leave, right? You want to show how your health center is going to support staff, even if they are having to work really hard, right? make sure that your job application process is as user-friendly as possible, right? I've skipped a lot of job applications or kind of saved them for the end. If it was one of those things where it's like, send us your resume, but also copy and paste it into a million little boxes on this like really cumbersome online form, right? So whatever kind of format you use, make sure it's as user-friendly as possible and kind of reduces the work burden on the person who might be, you know, writing 50 job applications to try to get a job, right? It always depends on what the job hunting environment looks like. But I definitely, you know, in some cases filled out like 100 job applications in a couple weeks. And I definitely skipped the ones that were harder to fill out because you had to retype every single little thing instead of just being able to say, send a resume and cover letter or something like that. All right. Oh yeah, and making sure that your job applications are, you know, accessible. So that they're, you know, if the person's going to be filling them out online or whatever, the text readers and everything work. That's going to be probably dependent on the site that you use for people to submit job applications for the most part. Also making sure that they avoid, you know, obviously things like gendered language and some of these things, and making sure that you're taking into account these JEDI, justice, equity, diversity, and inclusion principles, right? Making sure that you are not just reaching out to the same group of people over and over, because one, that's not very equitable, it doesn't promote inclusion, but also it limits who you're recruiting, right? And I have heard stories from people who, you know, the organization told them like, this is the most diverse recruiting class we've ever had. And the person said, why was that? And they said, well, we just kind of changed from our old ways, which kept a very narrow segment of people that we were recruiting. And we really made an effort to expand, to reach out to other organizations, to reach out to other academic institutions, and through other routes, through other posting boards, right? Some of these organizations on this slide have job posting boards, and you can put advertisements on them, and you can reach a much more diverse pool of candidates, right? And so just being sure to reach out. And remember too, that academic organizations usually have, you know, alumni pages and job posting boards and, you know, email listservs. I still get one from, you know, to my old grad school email that they send out all the time, just job postings for people that were in the School of Government was where I did my my degree. And they just send out job posting things to people. And so reaching out to those can be really useful because they can reach a really large pool of potential applicants. So that's my like really quick overview of kind of the partnership things and some of the job ad stuff. Again, please reach out to us if we can help you out with, you know, one-on-one TA, or just look through our site. We do have a much longer version of the job postings webinar that Michelle and Helen have done. And it's really good, really comprehensive, and they provide examples of job postings and really go into it. Okay. So hopefully you all have kind of some next steps planned. Patricia, best of luck. I do think you're on a really good course. If we can support you at all, let us know. And Joan as well. Thank you both for being here today. And certainly if you have any questions or need anything, reach out to us. I think there will be an evaluation popping up on the screen in a second. If you don't mind filling that out real quickly for us, it only takes a few seconds. And that's very helpful for our HRSA deliverables.
Thank you for hosting this.
Yeah, absolutely.
It's been rewarding.
Well, good. I'm very glad. And thank you so much for being here and for all your discussion and contribution over the time. If you all are just super bored, have nothing to do, there might be a pool there or maybe a place to garden, I don't know. But we have our conference in Washington, DC at the end of July. And so you can, this web page has the link on it, or I'm sorry, the slide has the web page link on it. If you or you know of anyone who's interested in attending. And then also we have a new tool that we put together that's a financial impact assessment. You don't have to put in any hard numbers or anything. So it's to get kind of an idea of where your greatest financial impacts from your HPEP program are going to be. And so it's just kind of a useful assessment tool. We hope it's useful. Let me know if it's not, and we'll make it better. But I think it's a nice tool to just get a feel of like, where are the greatest impacts coming from, right? Are they coming from something more intangible, like, say staff retention and well-being, or are they coming from savings, with recruitment efforts, things like that. Helen also created a really good onboarding checklist. So again, when you are bringing people on board, making sure that it's kind of going beyond just the rote orientation where they learn where everything is, but they're really being paired with someone who's going to help mentor them through that transition and get them, into the health center, help bring them in, so that they're adding on as part of the team, and really getting the most support so that they integrate really well into everything. And then, of course, we have tons of other resources at the STAR Center and our newsletter. We just are putting the last couple episodes, I believe, of this season of our podcast. And Michelle has done some really excellent interviews with folks. And there's our information. Thank you, Patricia. And yeah, thank you both again. I will let you get on with your days.
Which one's the podcast?
It is the second link. So on the second to last page.
Okay, STAR Center Talks.
Yeah, and
Okay.
I don't know if I can copy the link from there, but if you go to our website and type in STAR Center Talks, that will come up. Oh, there we
Okay.
go. Mariah just put the link in the chat. And yeah, there are some really
Awesome.
excellent interviews in there.
Okay, great. Thank you.
The final episode will actually be with a staff member from TAC. So there's
Oh,
that
yeah.
connection. It's not out yet, but it will be.
Well, thank you guys so much. This has been great.
Yeah, thank you. Thank you both for being here. And yeah, please reach out anytime if you need anything. And otherwise, I hope you enjoy your summer, get some pool time in that 56-degree weather.
All right, will do. Thank you guys.
All right.
Bye.
Take care, everyone.
Okay, bye.
Bye.